Hepatic disorders. As we review the liver, I want you to look at and review the anatomy and physiology of the liver, where it's positioned, and right now we'll begin with the liver function. So as we look at the functions of the liver, these would include glucose metabolism. With this function, the liver converts glucose into glycogen for storage and then converts it back to glucose, and that process is called glucolysis. And glucolysis is the ability to maintain normal levels of glucose in the bloodstream. Glucogenesis occurs when amino acids are used to synthesize glucose in cases of hypoglycemia. Ammonia conversion. So this is a byproduct of glucogenesis. The liver converts ammonia into urea, and then that is excreted in the urine. Ammonia is produced by bacteria in the GI tract. Protein metabolism. In this role, the liver synthesizes all plasma proteins except gamma globulin, and vitamin K is used to synthesize prothrombin. Fat metabolism. Liver enzymes break down fats when the availability of glucose is limited. For example, in cases of starvation or uncontrolled diabetes. This results in ketones being produced. Fatty acids and metabolic waste help synthesize cholesterol and other lipids. Vitamin and iron storage. Vitamins A, B, D, B complex, iron, and copper are stored in the liver. Drug metabolism. Barbiturates, opioids, sedatives, amphetamines are all metabolized in the liver. The metabolism may cause inactivation or activation. Often, these processes will cause a binding with other compounds, and then the byproduct is excreted in the feces or the urine. This function of the liver affects the bioavailability of medication. And the bioavailability of medication speaks to how much of the medication actually reaches the systemic circulation. Bile formation. So bile is made continuously. It's made of water, electrolytes, lecithin, complex lipids, and bile salts. So bile is collected and stored in the gallbladder and then emptied into the intestines when needed for digestion. Bile plays a role in breaking down fats. After digestion, some of the bile salts are excreted in the feces, and the liver reabsorbs the rest. Bilirubin excretion. So bilirubin is a pigment byproduct of hemoglobin breakdown. The liver chemically alters it to make it more water soluble. It's then secreted into the bile and carried through the GI tract for partial excretion in the feces, or it enters the systemic circulation for excretion by the kidneys. So when you're doing an assessment um, on a patient on their liver condition, you want to start out with a health history. You want to ask about previous exposures to hepatic toxic substances or infectious agents. This might be through their occupation, recreational, or it might be an issue with their travel history. You want to ask about alcohol and drug use. You want to ask about medications such as acetaminophen, valproic acid, which is an anticonvulsant, and it's also used for migraines. You want to ask about over-the-counter meds. You want to ask about lifestyle behaviors, particularly psychiatric or psychological issues, because that will affect the medications that they may take. You want to ask about a family history of cirrhosis, gallstones, alcohol abuse, genetic disorders, symptoms of jaundice, altered mental status. You want to ask if they bruise easily. You want to ask about amenorrhea in women, and that's the cessation of regular menses for 3 months, or the cessation of irregular menses for 6 months. And of course, these are for women who are not in menopause. So now that you've collected information regarding their health history, you want to proceed to the physical examination. To examine the liver, you want to palpate the liver for enlargement, tenderness. You want to palpate in the right upper quadrant over the liver. You also want to check the skin, mucosa, and sclera for jaundice. You want to check the extremities for muscle atrophy, edema, excoriation due to itching. You want to check the skin for ecchymosis or spider angiomas or palmar erythema. Just as a note, with palmar erythema, that's redness on the palms, the exact cause is unknown, but it's believed to be caused by dilation of blood vessels due to hormonal changes. You also want to assess for ascites, which is edema in the abdomen. You want to check for edema in the legs and ankles. You want to check for dark urine, pale stool or steatorrhea. You want to check for nausea or vomiting, abdominal pain. You want to check for asterixis, which is an involuntary flapping movement of the hands. And it should be noted that some of these symptoms are not exclusive to a liver condition. It may be from something else, but this is something that is noted that you should note, especially the asterixis and with that flapping movement of the hands. Next, let's look at the diagnostic evaluation tools that are available. This would include liver function tests such as the AST, ALT, total bilirubin, clotting factors such as the prothrombin time, ammonia levels, protein and albumin levels, as well as serum alkaline phosphatase. These labs help to identify the liver's ability to function properly in the role it plays in the body. Each lab provides specific information such as the liver's ability to metabolize fats, proteins, and medications, as well as its ability to excrete bilirubin. Liver biopsies are used to evaluate diffuse disorders of the parenchyma, or working tissue of the liver, and to diagnose space-occupying lesions. You want to watch out for hemorrhage because the most common complication is peritonitis caused by blood or bile. This procedure is done percutaneously. It is ultrasound guided and transversely through the right jugular vein to the right hepatic vein. It's done under fluoroscopy or laparoscopy. An ultrasound, CAT scan, and MRI is used to identify the normal structures of the liver and any abnormalities of the liver and biliary tree that may exist. An exploratory laparotomy is when the abdomen is surgically opened to evaluate the abdominal organs. It's usually done after a traumatic injury or for abdominal tumor removal. An exploratory laparoscopy is whereby a fiber optic endoscope is inserted through an incision in the abdomen to examine the liver and other pelvic structures. This may be used for biopsies, tumor staging, and to identify causes of ascites. And this link to a liver biopsy can give you more insight so that you can see it being done. So what are some of the clinical manifestations of liver dysfunction or hepatic dysfunction? So you might see jaundice. You might see portal vein hypertension. You might see ascites, esophageal varices, hepatic encephalopathy, and coma. You may see general edema, vitamin deficiencies, metabolic abnormalities, pruritus, or bleeding. And I'm going to go into further detail for all of these. So up until this point in your nursing career, you probably were only asked to identify jaundice, as, the person's sclera is yellow, or their skin or their nail beds are yellow, and you just say they're jaundice. But I want to go into a little more detail about jaundice. There are multiple types. The first type is hemolytic. And generally, these types are based on the etiology or the cause for the jaundice. So the hemolytic type of jaundice, you see an increased destruction of red blood cells. And it's because the liver cannot excrete the bilirubin as fast as it is made. You won't notice any bilirubin in the urine. There will be an increase in urobilirubin in the feces and urine. And if this condition is prolonged, it can result in pigmented gallstones, and the person would have central nervous system effects. You will see this in conditions such as hemolytic transfusion reactions or other hemolytic disorders. Hepatocellular. This is when damaged liver cells can't clear the normal amounts of bilirubin from the blood. Liver cell damage may be caused by hepatitis, Epstein-Barr virus, yellow fever, chemical toxins, alcohol, cirrhosis, and it's all dependent upon the cause. But if the cause is such as like a type of like the use of an antibiotic, it can be completely reversible. So someone with a hepatocellular type of jaundice, their condition may be mild, in which the jaundice is not obvious, or it may be severe. If the person with hepatocellular jaundice also experiences headaches, chills, and fever, then it is suspected that the cause is viral. And the person with the hepatocellular jaundice would have increased serum bilirubin, increased urine urobilirubin, and then the AST and the ACT will be elevated as well. Obstructive jaundice, there are two types. It may be an extrahepatic obstruction, meaning there's an obstruction from outside of the liver, or it may be an intracellular or intrahepatic obstruction. And this is the stasis of bile within the liver. So the obstructive type of jaundice may be caused by medications such as statins, sulfonylureas, hormones, or antibiotics. And so what happens in this case is that bile flow backs up and the bile is reabsorbed into the bloodstream and then excreted in the urine. The urine becomes deep orange and foamy, and the stools, on the other hand, become light and clay colored. And this is because there's a diminished amount of bile in the GI tract. You might see an obstructive type of jaundice as a result of prolonged hepatocellular jaundice. And our next type of jaundice is hereditary. And this is when you have elevated bilirubin levels. The person is jaundiced, they look jaundiced, but the LFTs and the histology are within normal limits. And there's also no hemolysis. So you might see this in Gilbert syndrome or in the cholestatic jaundice of pregnancy, and that's due to elevated hormones. In the hereditary type of jaundice, you will also see the person will complain of dyspepsia, intolerance to fatty foods. And when you look at their lab values, their AST, ALT will rise moderately, but the bilirubin and ALK phosphatate will really become elevated. So overall, jaundice is caused by elevated bilirubin in the blood, bilirubin levels in the blood. It results in a yellowing or greenish yellow tinge of the body tissues. It becomes clinically evident when the serum bilirubin levels exceed 2.0 milligrams per deciliter. Let's get into portal hypertension in a little more detail. So, portal hypertension is when there's increased pressure throughout the portal venous system, and that results from the obstruction of blood flow into and through the damaged liver. This most often occurs with hepatic cirrhosis, but it can also occur in a non-cirrhotic liver disease. And so clinical manifestations would include splenomegaly, they'll have an enlarged spleen, ascites, and esophageal varices. So as you look at the slide for the portal hypertension, so the pressure increases. You will have an increase in the pressure of the peritoneal capillaries, and that's what causes the ascites. You'll have a portal systemic shunting of blood. And so what that will do is it's a shift of the blood, and that will cause the development of collateral channels. And one of the results of that is everything becomes swollen. You may have esophageal varices, caput medusa, or hemorrhoids. And that's just from that pressure. It's almost like pressure and you have a balloon that's becoming enlarged. Also, with the shunting of blood, you have a shunting of ammonia and toxins from the intestine into the general circulation. And so remember we spoke that ammonia is caused by the breakdown of proteins in the digestive tract. So as the ammonia is produced and gets into the general circulation, that will cause the hepatic encephalopathy. Another consequence of this portal hypertension is the enlargement of the spleen. And that can result in anemia, leukopenia, and thrombocytopenia. So when you review that, think about the role of the spleen. What is the function of the spleen? And that'll help you to understand some of the mechanisms that disturbed liver function can result in. And this next slide gives you just another indication of what's happening when the pressure in the portal vein increases. There was a term, the caput medusa, and that is distended and enlarged superficial epigastric veins. So everything becomes swollen, just engorged because of this high pressure. So for ascites, the prevailing theory is that it's essentially an end result of the portal hypertension. And they're not quite sure about the mechanism, but they do have theories that they are researching. In order to do the assessment, the physical assessment, percussion of the abdomen is done to look for the shifting dullness in the abdomen because of the fluid, or by checking for a fluid wave. They also use a ballottement technique, and that's whereby palpation is used to identify an enlarged organ when the ascites is present. If you look on page 1386 in your Brunner textbook, you can see a demonstration um, of a fluid wave assessment by fluid wave or ballottement. Some of the symptoms that the person may have will be shortness of breath, abdominal striae, distended veins all over the abdominal wall, umbilical hernias, fluid and electrolyte imbalances, increased abdominal girth, and rapid weight gain. So it should be noted also that some of the causes, additionally, other than the portal hypertension, could be because of like cancer, the result of uh, cancer and the protein deficiency. So in ascites, you have large amounts of albumin-rich fluid, sometimes 20 liters or more in severe cases, and this fluid accumulates in the peritoneal cavity. So because of the fluid shift from the serum to the peritoneal cavity, the osmotic pressure of the serum decreases, and then you have a manifestation of the symptoms. In ascites, there is a cyclic vasodilation of a portion of the GI vascular circulation. There's a failure of the liver to metabolize aldosterone, and that in turn increases the sodium and water retention by the kidneys, which will cause an increase in intravascular volume and decreased albumin production by the liver. Management involves dietary control. So you want the person to have a negative sodium balance. So in order to do that, they're often placed on a low sodium diet, 2 grams of sodium a day. You want to be careful of salt substitutes that are on the market because some of them contain ammonia, which can lead to hepatic encephalopathy. And they also contain potassium, which is a problem for those with impaired renal function. So if the diet control doesn't work, the sodium is further restricted and or a diuretic might be added. A couple of the diuretics they may use, one is spirolactone, and that is the diuretic of choice because it helps to prevent potassium loss. Lasix, on the other hand, is used cautiously because the person is at risk for hypokalemia. Ammonium chloride and acetazolamide or Diamox is contraindicated because it may cause hepatic encephalopathy. So in these cases, although you want to have that balance of potassium, And the only time you really want to watch potassium is if they have a renal dysfunction as well. But when the person becomes hypokalemic, ammonia in the systemic circulation increases. And it's that ammonia that causes impaired cerebral function and encephalopathy. The person should not lose more than 1 kilogram per day, or those with edema, not more than 0.5 kilograms a day. So fluid restrictions are not recommended unless the sodium is low. So the next thing in management that the person may be ordered on is bed rest. Because when a patient with ascites is upright, it activates the renin, angiotensin, aldosterone system and the sympathetic nervous system. And all that is going to cause the glomerular filtration rate to decrease and sodium to be retained. And this is because of the fluid pooling in the peritoneal cavity. It mimics hemorrhage in that it decreases perfusion to the kidneys. And so then that would cause the kidneys not to respond well to a loop diuretic. And they can develop a pre-renal acute kidney injury. And these slides show examples of ascites. The second slide, the slide on the right, shows what an enlarged liver in the peritoneal cavity looks like. Paracentesis is a treatment whereby they remove the fluid from the peritoneal cavity, the fluid that accumulates due to the ascites. So with paracentesis, the fluid is removed from the peritoneal cavity through a puncture or small surgical incision that goes through the abdominal wall under sterile conditions. And this is primarily used, this is also used for diagnostic purposes in addition to massive ascites. Or it may be used prior to starting peritoneal dialysis or surgery when nutritional and diuretic therapy has failed to reduce the amount of ascites that a person has. Paracentesis is used in combination with a sodium poor albumin, sodium poor diet, as well as sodium poor albumin or other colloid to correct the intravascular hypervolemia. Okay, so let me say that again. Paracentesis is used in combination with sodium poor albumin or other colloid to correct the intravascular hypervolemia. This treatment will result in increased cardiac output, and increased kidney perfusion and performance. Because of liver disease, that it's cyclic, meaning you remove the ascites, but the condition remains, and so the ascites comes back. So they often have to repeat the paracentesis. This procedure may be done at home with the patient in cases of malignant disease, in which the goal is to just manage the symptoms of ascites. And in those cases, a Pleurex catheter, Plurx catheter, is inserted into the abdomen. And that's used to drain the ascites. They have a valve on the catheter. It'll click into a vacuum bottle, and the negative pressure in the bottle will drain the fluid. In these cases, only about 500 mLs are drained at one time, and that's to prevent hypovolemia and hypocalcemia. The problem with this is that it places a person at a big risk for infection. Esophageal varices are dilated veins that are full of twists and turns, that's called tortuous, that occur in the esophagus or stomach. These are collateral blood vessels caused by portal hypertension that result from obstruction or abnormalities of the portal vein circulation within the damaged liver, splenic vein, or superior vena cava. Bleeding esophageal varices are a life-threatening emergency due to the possibility of hemorrhagic shock caused by the massive blood loss. Contributing factors of hemorrhage include muscular exertion with lifting heavy objects, straining during defecation, sneezing, coughing, vomiting, esophagitis, irritation by poorly chewed foods, or acid reflux from the stomach when a person has esophagitis. Also, medications that might erode the esophageal mucosa, for example, non-enteric coated aspirin or chemotherapy. Clinical manifestations include hematemesis or vomiting blood, melena, a decline in mental and physical condition, along with a history of alcohol abuse. You want to also watch out for signs and symptoms of shock. That's if they have cool, clammy skin, low blood pressure, high heart rate. Diagnostic tests include endoscopy, and this is used to identify the source of the bleeding and to facilitate treatments such as sclerotherapy. Sometimes an endoscopic video capsule can be used to detect esophageal varices. For patients at high risk of esophageal varices, they are diagnosed and treated, and the patient is screened regularly. Portal hypertension measurements are also done. These are performed on clients with dilated abdominal veins and hemorrhoids, as well as those with enlarged spleens or ascites. This measurement can be taken indirectly or directly. Lab tests, liver function tests are often performed. AST, ALT, serum alkaline phosphate, serum proteins, and bilirubin. Management and treatment. Drug therapy includes vasoactive meds, which are given in suspected cases even before the endoscopy. And this might include adrenaline or nitrates. If the person is actively bleeding, octreotide, octreotide, is given as well. This is the drug of choice because it doesn't have the vasoconstrictive effects on the extremities the way vasopressin does. Vasopressin is a potent vasoconstrictive medication. It's contradicted in clients with coronary artery disease because it may precipitate an MI. It may also cause a dysrhythmia and extremity ischemia. It's only used in urgent situations or when octreotide is unavailable. Beta blockers, such as propranolol or Inderal, are often given to both prevent the initial bleeding or in instances to prevent rebleeding. It is not given during an acute hemorrhage. Balloon tamponade is also used, and this is not used often, but it may be used to temporarily stop a massive bleed. The risks include airway obstruction, aspiration of gastric contents or blood into the lungs, ulceration and necrosis of areas of the nose, esophagus, or stomach, and this must be removed in 12 hours or less. Sclerotherapy is when a sclerosing agent is injected. It's a medication, and this is injected through an endoscope into the adjacent to the bleeding varices, and this will promote a thrombus formation and eventual sclerosis of the area. This procedure is used for acute hemorrhage. After the therapy, antacids, H2 antagonists, or PPI, proton pump inhibitors, are given to counteract the chemical effects of the sclerosing agent, as well as acid reflux that may result. A TIPS procedure is when a cannula is threaded into the portal vein by the transjugular route. An expandable stent is placed to form an intrahepatic shunt between the hepatic circulation and the hepatic vein. This will rapidly reduce the portal hypertension pressure and as a result decrease the hemorrhage. This procedure is also used to treat ascites. It is used for high-risk patients with cirrhosis and active bleeding at the time of endoscopy. It is expensive, and complications include bleeding, sepsis, heart failure, organ perforation, shunt thrombus, and progressive liver failure. Surgical procedures include ligation procedures, decompression stents. These are not the procedures of choice. These are considered rescue therapy as the last resort, or those who aren't candidates for transplant, or as a bridge to a transplant. And the reason is because there's a significantly high risk of mortality. as well as a high risk for a hepatic vein thrombus, encephalopathy, and accelerated liver failure. Finally, nursing interventions include monitoring physical condition for complications, example, shock, etc. And you want to monitor their response to the therapy. If esophageal rest is required, you want to give parenteral nutrition, such as TPN. You want to make sure you provide oral care, administer blood products and medications as ordered, provide education, as well as emotional support. With this slide, you have you see where the sclerosing agent, okay, the needle is inserted, and then you have the bleeding esophageal varices, and then you see on the right where the bleeding is reduced. On this slide, you see the balloon tamponade. You see where the balloon is introduced through the nose, very similar to an NG tube. Okay. And then at the end of it is a balloon-like piece of equipment, and then it expands and cuts off the bleeding vessel. And again, there are many risks with the balloon tamponade, and this is to only stay in place for 12 hours or less, and the person must be actively bleeding. It must be an urgent situation. On this slide, we have the esophageal banding therapy, and you see on slide A, well, you see on slide B actually, where the band is there. And then you see on slide A where the varice, or varix for single varice, is being sucked up. And so that's reducing the size of it. And then again, there's another picture, again, of the sclerotherapy. And so our next therapy, our next treatment, which I will go over, is the TIPS procedure, or the transjugular intrahepatic portal systemic shunt. So in this procedure, a cannula is threaded into the portal vein by the transjugular route. An expandable stent is placed to form an intrahepatic shunt between the hepatic circulation and the hepatic vein. This rapidly reduces the portal hypertension, okay, so decreases the pressure, and as a result, it decreases the hemorrhage. This can also be used to treat ascites. It's used for high-risk patients, such as patients who have cirrhosis of the liver and who are actively bleeding at the time of endoscopy. This is an expensive procedure, and complications include bleeding, sepsis, heart failure, organ perforation, shunt thrombus, and progressive liver failure. So it may cause the liver failure to become worse. So with these treatments, as a nurse, you want to monitor Again, it depends on what the risk for the procedure will be. But in general, you want to monitor for hemorrhage. You want to monitor the circulation, especially with the vasopressins. You want to monitor their vital signs. You want to monitor their central nervous system, their mental status, in case they have altered mental status. You want to monitor their lab values, in particular, their liver function tests, their electrolytes. And it's also important to educate your patients to know what signs and symptoms they should watch out for, and when to notify you, um, and what to expect, because everything happens quickly if it's an emergent case, and it can be quite a shock. Okay, and they could be quite fearful, especially if they're bleeding, if they're hemorrhaging and not feeling well. Hepatic encephalopathy assessment and management. Hepatic encephalopathy is a life-threatening complication of profound liver failure. The onset is subtle and detected by neural changes. This can occur in acute and chronic liver failure. In this condition, ammonia entering the brain causes CNS depression that inhibits neurotransmission and synaptic regulation. Ammonia buildup can be caused by the liver's inability to detoxify the blood or by portal hypertension, allowing portal blood to enter the systemic circulation. Circumstances include bacterial digestion of dietary or blood product protein in the GI tract, for instance, from a GI bleed. It can also be caused by a high protein diet, uremia, or bacterial infection, just to name a few. Clinical manifestations include mental status changes, motor disturbances. In stage 1, you may notice lethargy, and that may advance to confusion in stage 2, and eventually progress to stage 4, which would include coma and seizures. Deterioration of handwriting and inability to reproduce a simple figure in 2 or 3 dimensions is called constructional apraxia, and this is seen very often in stage 1. Asterixis, which is called liver flap, is when the hands involuntarily flap when the arms are extended and the hand is held upward in a dorsiflexed position. Another manifestation clinically is fetor hepaticus. And this is a sweet, slightly fecal odor to the breath. And it's thought that this is of intestinal origin, and it's described as being similar to acetone or mowed grass or old wine. And it is prevalent when there is collateral portal circulation with chronic liver disease. Medical management at least, focuses on treating the cause of the high ammonia levels and decreasing them. So lactulose is given, and this will help decrease the ammonia levels by causing the person to defecate and getting rid of ammonia that's in the bowel. and decreasing the bacteria, which would cause the increase in ammonia levels. Also, if the issue is a high protein diet, the person is placed on a low protein diet because the metabolism of the protein in the bowel will elevate the ammonia levels. Antibiotics are often given, and this decreases the bacterial level in the bowel, so that there's fewer number of bacteria or the normal flora, such as E. coli, that would digest the protein. Neuro and handwriting checks are done to evaluate the person's level of neurological deficit. As far as nursing, you would want to provide safety measures, such as being sure that the side rails are in place, being sure that you're doing frequent checking of the patient. And this is because they're at risk for falling. And if they fall, because they have liver disease, they may be at risk for bleeding. They are often confused and may be combative, and maybe there's a risk of hurting themselves or others in that manner. Because of the central nervous system depression, you want to monitor their respiratory rate, their airway, and their labs for fluid and electrolyte imbalances. Keep in mind some of the potential nursing diagnoses with hepatic encephalopathy would include these issues related to disturbed thought processes, along with risk for aspiration, impaired gas exchange, impaired mobility, impaired nutritional intake, risk for injury, and so forth. And the labs you would want to monitor, of course, are the fluid and electrolyte labs that will let you know about that, as well as ammonia levels. Our next clinical manifestation is hepatic cirrhosis. With hepatic cirrhosis, you have it's where the normal liver is replaced with fibrotic tissue. And so this may be alcohol induced or non-alcohol induced. If it's caused by alcohol, of course, that's one that many of us are familiar with, and that occurs over time. And just generally, it's the alcohol that causes this fibrous tissue to replace the normal tissue. If it's non-alcohol induced, two types of diseases that are under this category of non-alcohol induced hepatic cirrhosis include non-alcoholic fatty liver disease, or NAFLD, or non-alcoholic steatohepatitis, which is NASH, NASH. So these are most often caused by obesity or type 2 diabetes. It may also be caused by malnutrition or exposure to chemicals such as arsenic, or infections such as the hepatitis virus. Non-alcoholic induced hepatic cirrhosis, as well as the alcohol-induced hepatic cirrhosis, may be categorized as compensated or decompensated. In Brunner, page 1407, chart 4910, gives you signs and symptoms of compensation and decompensation. So if the cirrhosis is compensated, this means that it's less severe. The person complains of vague symptoms. They'll have liver enlargement, which is usually found upon routine examinations, or they may complain of slight abdominal pain. Once the condition becomes decompensated, they will have a failure to synthesize proteins and clotting factors. You will also see portal hypertension, ascites, edema in the extremities, varices. You may see hepatic encephalopathy. They may have indigestion or altered bowel function due to obstruction. They may have spontaneous bacterial peritonitis. You will see vitamin deficiencies and anemia as well. Nursing management of cirrhosis include dieting and activity. So if there is no ascites, edema, or signs of impending coma present, the person is placed on a protein diet of 1.2 to 1.5 grams per kilogram per day diet with supplements of vitamin A, C, K, B complex, probiotics, folic acid to prevent anemia, sodium restriction to prevent ascites. Now keep in mind, the liver, in a case of cirrhosis, cannot store vitamin B, so it must be supplemented. If ascites is present, small frequent meals may be better tolerated. And you want to increase the carbohydrates. If steatorrhea or fatty stools are present, you want to give water-soluble forms of vitamin A, D, and E. For skin care, you want to make sure that there are position changes. Do not apply adhesive tape or use irritating soaps. You want to apply lotion to the skin to minimize scratching, because these patients will have pruritus due to the dry skin. You want to prevent injury. If hepatic encephalopathy is there, make sure you reorientate the patient, use the side rails, etc., to prevent injury. They will have a prolonged prothrombin time, so that they're at risk for bleeding. So you want to use an electric razor instead of a safety razor. You want to have them use soft bristle toothbrushes. You want to apply pressure to a venipuncture site more than usual. And To prevent injury caused by fluid volume excess, you want to decrease their sodium intake, give diuretics as prescribed. You want to perform daily weights and measure the abdominal girth daily. And you want to measure their INOs, and they should be on a fluid restriction if ordered. Let's talk about liver cancer. Liver cancer, you can have primary liver cancer or liver metastasis. And the difference is that with the primary liver cancer, that's where the tumor begins in the liver. With liver metastasis, the primary site was elsewhere and it metastasized to the liver. It's interesting to note that few cancers originate in the liver, and benign tumors were uncommon until the widespread use of oral contraceptives. Primary liver cancer is usually associated with chronic liver disease, hepatitis B and C infections, and cirrhosis, but there are other less common causes. Metastasis from other sites is more common than primary liver tumors. Liver metastasis is often the first sign of cancer in an abdominal organ. Symptoms of liver cancer is consistent with other liver pathology, meaning they may have right upper quadrant pain, back pain, weight loss, an enlarged liver, jaundice, etc. Diagnostics are the same as the other liver pathologies except with needle biopsy. For liver cancer, needle biopsies are used less often because they don't want to spread, they don't want to cause tumor seeding, especially in candidates for liver resection or transplant. So you don't want the tumor cells to be seeded elsewhere in the body by performing liver biopsies. Medical and nursing management. Medical management of liver cancer includes radiation therapy, chemotherapy, percutaneous biliary drainage, laser hyperthermia, immunotherapy, arterial embolization, ultrasound-guided injection of alcohol to cause dehydration of the tumor cells. So they'll put alcohol, like your isopropyl alcohol, into a tumor to dehydrate the tumor cells. They may also do a lobectomy. Now remember, you can live with part of a liver. They may do an ablation, or they may do entire transplantation of all or part of a liver. Nursing management includes education. So with education, you want to tell them about the equipment, how to care for it. You know, if they have an implanted port for chemotherapy, they may have biliary tubes that would drain some of the exudate. You want to provide emotional support. And then you also would want to give transfusions and medications as ordered. It's important to consider the ethical dilemmas that are related to organ transplant in patients with liver disease due to life choices. For instance, if they develop the liver disease as a result of alcohol abuse or as a result of substance abuse. Other hepatic conditions include those who experience a liver transplant. With liver transplant, you want to consider ethical dilemmas that could arise related to organ transplants in patients with liver disease due to life choices, such as alcohol abuse, substance abuse, etc. When caring for someone who has had a liver transplant, preoperatively, you should provide education, support the client and family. You want to help treat malnutrition, fluid and electrolyte imbalances, massive ascites that the patient may have experienced or currently is experiencing prior to the transplant. Postoperatively, you want to provide education regarding medications, rejection, maintain the environment that is conducive to immunocompromised patients not becoming infected. You want to monitor their hemodynamics, provide pulmonary hygiene, the use of the incentive spirometer, coughing and deep breathing, etc. Their activity, and you may also be monitoring the donor as well. Liver abscesses is another hepatic condition. It may be amoebic, which often occurs in developing countries due to poor sanitation and hygiene. Or it may be pyrogenic, and this is often seen in more developed countries, such as the United States. Pathophysiology of this is when an infection begins in the GI or biliary tract, and then toxins from the bacteria destroy neighboring liver cells, causing necrosis of tissue that harbors the organisms. White blood cells respond to the infection and create an abscess cavity with living and dead white blood cells, bacteria, and liquefied liver cells. Clinical manifestations include sepsis, fever, chills, malaise, diaphoresis, right upper quadrant dull pain, jaundice, and pleural effusions. Diagnostic tests include aspiration of the liver abscess, CT, MRI, and it's treated with antibiotics IV, with drains, and possibly surgery if necessary. Nursing care depends on the physical status of the patient and the medical treatment provided, but it may include administration of medications and fluids, care of the drains, education, skin care, and hemodynamic monitoring. Let's talk about the different types of hepatitis. So there is there are 5 types of hepatitis: A, B, C, D, and E. Hepatitis is a systemic viral infection. It can cause necrosis and inflammation. So talking about hepatitis A. Hepatitis A, like many of the other hepatitis infections, is easily transmitted, and there may be a high morbidity. Hepatitis in general affects up to about 1% of the US population. You can review table 49-4 on page 1398 of your textbook for signs and symptoms and additional information. If hepatitis is treated with an antiviral, the medication will usually have an ending of VIR, like acyclovir. So hepatitis A is spread by poor hand hygiene. It is the fecal oral route, meaning hand to mouth contact, or other close contact such as oral to anal or anal intercourse. The incubation for hepatitis A is 2 to 6 weeks. It can also be caused by ingestion of contaminated food or water. This hepatitis is not chronic. Many of these patients do not have jaundice, and it can be more severe in patients over 40 years old. There is a vaccination available, and it is 95 to 100% effective, and it's given in 3 doses, 2 to 3 doses. It's recommended for children ages 1 year or older. It's also recommended for high-risk groups such as healthcare personnel. It's recommended for IV drug users, staff at daycare centers, and travelers to developing countries. Hepatitis B, on the other hand, is bloodborne. It's a major worldwide cause of cirrhosis and liver cancer. It has a long incubation period of 1 to 6 months. Risk factors include unprotected sex with infected individuals, infants born to infected mothers, contact with infected blood, injectable substances, and hemodialysis patients. Hepatitis B may become chronic, and the available vaccination is 90 to 95% effective in healthy individuals. It is included as part of childhood vaccination. Hepatitis C is transmitted bloodborne. It's the most common bloodborne infection. It is the cause of 1/3 of the cases of liver cancer and the most common reason for a liver transplant. Symptoms are usually mild, and the incubation period varies from 15 to 160 days. Risk factors: blood transfusions or organ transplants before 1992, sexual contact, sharing contaminated needles, IV or injection of drugs by substance abusers, or under not keeping with asepsis technique, unintentional needle sticks. There is no vaccination for this, and the best way to prevent this is to avoid high-risk behaviors. Hepatitis C is usually treated with antiviral agents, and the symptoms are usually mild. Hepatitis D. Only patients with hepatitis B are at risk. Hepatitis D, so if a patient does not have hepatitis B, they cannot develop hepatitis D. Hepatitis D is likely to develop into fulminant liver failure or chronic active hepatitis and cirrhosis. Fulminant liver failure is a sudden, severe onset of acute liver failure that occurs 8 weeks after the first symptoms of jaundice. This is common among IV or injectable drug users. You might find it in hemodialysis patients. You may see it in recipients of multiple blood transfusions. Again, this is seen only in patients who have hepatitis B. The incubation period is 30 to 150 days. And again, there's no vaccination for hepatitis D. Hepatitis E. This is transmitted by the fecal oral route, caused by ingestion of food or water contaminated with fecal waste. It resembles hepatitis A in that it has an abrupt onset. It is self-limiting, and it is not chronic. Self-limiting means that it will resolve on its own. Hepatitis E has an incubation period of 15 to 65 days. Nursing diagnoses for clients with cirrhosis of the liver would include activity intolerance, imbalanced nutrition, impaired skin integrity, and risk for injury and bleeding. So now it's important to understand that hepatitis may eventually lead to cirrhosis of the liver, as well as other conditions such as alcoholism, or you may have non-alcoholic cirrhosis of the liver.